Hello, everyone, and welcome to Ask the Expert, FTD and COVID-19, the third in a special series of AFTD webinars. We understand that the COVID-19 pandemic is having significant impact on people living with FTD, their care partners, their families, and the health professionals who support them. To that end, we have developed a special series of webinars to bring you educational content designed to help families manage the FTD journey during this difficult time. I'm Susan Dickinson, CEO of AFTD, and our presenter today is Dr. Bruce Miller, the Director of the Memory and Aging Center at the University of California, San Francisco, and one of the country's leading FTD experts. On behalf of everyone here, I'd like to thank you for joining us today. Before we start, we want you to know that this special webinar series is brought to you by the generous support of our 2020 Educational Conference sponsors. We'd especially like to acknowledge our platinum sponsors, Elector, Biogen, Ionis, and Buffalo Trace Distillery, gentlemen of the Pappy Van Winkle Classic. Thank you for making today's webinar possible. Thanks also to our gold, silver, and nonprofit partner sponsors for your contributions to bringing this content to the people we serve. We encourage your participation in this interactive event today. As the discussion unfolds, Dr. Miller and I are here to answer any questions you may have about the state of FTD research and about FTD and COVID-19. You submit any questions you have by typing them into the questions section, which is located toward the bottom of your control panel on your screen. Please send your questions as you think of them, and we will ask as many as possible at the end of the presentation. Our audience will be muted for the duration of the presentation. This helps to keep the background noise to a minimum so that everyone can hear the presenter clearly. If you have any technical issues, please write a message in the questions box, and AFTD's Lauren Gauthier and Dina Chisholm will try to address them with you. We're recording this presentation, and we'll post it on AFTD's website and YouTube channel. Please share it with others you think may be interested. And now it's my pleasure to introduce our presenter, Bruce Miller, MD. Dr. Miller holds the A.W. and Mary Margaret Clausen Distinguished Professorship in Neurology at the University of California, San Francisco. He directs the UCSF Memory and Aging Center and is the director of the Global Brain Health Institute. He's the principal investigator of the NIH-sponsored Alzheimer's Disease Research Center and Program Project Grant on Frontotemporal Dementia at UCSF. In addition, Dr. Miller helps lead the Tau Consortium and the Bluefield Foundation, precision medicine collaborations which are focused on developing treatments for tauopathies and for progranulin-mediated forms of FTD. Bruce, it is truly a pleasure to welcome you today to our webinar, and I'm going to invite you to turn on your webcam. And for the first part of today's presentation, we're just going to have a discussion. And I'm quite sure that most of our audience is very aware of the seminal role you've played in advancing the field of FTD research in recent decades. So I'd like to start by asking you to share with us how you were first introduced to FTD and how and why it's become the focus of your career.
Susan, honored to be here with you today via AFTD, an incredibly important program that is decreasing the burden of caregivers across the world with this amazingly difficult illness. And we know that you caregivers bear the brunt of this disease, and we'll touch a lot on that today. So I became very interested in frontotemporal dementia when I was a fellow at UCLA in 1983. I worked with two people, Frank Benson, who was fascinated by the frontal lobes and what they did, and Jeff Cummings. And both Frank and Jeff believed at a time when no one else did that you could diagnose frontotemporal dementia, differentiate it from Alzheimer's disease, and I think importantly, they believed that this was an important illness. And so working under their mentorship and seeing the combination of these fascinating individuals with behavioral personality, motor changes, and their caregivers. I saw that caregivers gave so much back to these people and to society. And so I developed a passion to find better ways of diagnosing frontotemporal dementia I'll touch on today, I'm really proud. We're really, I think, on the verge of being able to treat frontotemporal dementia.
That's exciting. I'm curious, what 2 or 3 things do you think are the most important advances in recent years in caring for people with FTD and for their families?
Yeah, I think one thing clearly that is important is recognition of this as a real and important disease entity, and understanding how the behaviors of frontotemporal dementia can be so difficult for the person who was on the front line with the illness. So I think that's probably the most important thing, is recognizing that this is an illness. I think the second really important fact is that we now know that caregivers who have a loved one with frontotemporal dementia are at unusual stress and more likely to develop diseases of their own, physical diseases, mental health disorders, just by their heroic efforts to look after their loved ones. Then I think the third thing that I think we're slowly beginning to understand is that medicines that have been given to treat behavior and Alzheimer's disease often don't work, often make these people worse. And I think with organizations like AFTD, I think we are learning, working with caregivers particularly, about helping to change environments around these individuals to make it easier for the patient and the loved ones to cope.
Mm-hmm. Turning to the more immediate environment that we're all living in right now, I'm curious how the current pandemic has affected your work at the Memory and Aging Center, and specifically if your team is able to continue with diagnostic evaluations, or if it's changed the way you deliver care or interact with the people who have FTD and with their families.
Yes, I think almost from the beginning of this epidemic, we wanted to reach out to people. We know how hard it is. I think the double whammy is often having a loved one with FTD in the home, unable to go out. That's a huge problem with COVID. And then the second is the added responsibilities on caregivers. They have to do more. They have to get food. They have to protect their family. So this has been a really tough time for people who have a loved one with FTD. So we started almost immediately in San Francisco with sheltering. I'm extremely proud to say we have only had one death at our UCSF hospitals, which take care of many, many tens of thousands of people. So I think science applied to how to protect our population has made a big difference, and I think it's going to make a big difference across the country. So we've been doing telemedicine almost from day one. And I think it's not quite the same as being in the room with a patient and their loved ones, but it's pretty good. And so we have actually increased the number of people that we're seeing. We have a sense of urgency at the moment about this, and are actively trying to get people into our telemedicine programs. We're seeing people from all over the world via telemedicine. I think it works pretty well. And I think this is going to change us. I think of how many families who've come to us from across the country exhausted by the time they reach us, and and I think we can accomplish so much just by the computer. So I think this may allow us to reach more people at centers that are actively involved with telemedicine. And I expect that 20–25% of the people that we'll see in the future, we won't see in person, we'll see through telemedicine. And I think the good news about that is I think that caregivers, like the people listening today, will be able to get seen by experts immediately. I think at our center, once you're in our system, we are available to talk almost 24 hours a day. So I think with AFTD, with telemedicine, there are some nice things that are going to happen from the COVID epidemic. I know bad things too, but this is a good thing.
Yeah. Well, nice to find some silver linings anywhere these days, I know. Um, Staying with the coronavirus crisis for a moment, we know that the health and safety guidelines can be especially challenging for people, specifically with behavioral variant FTD. I know on our helpline, we're hearing from families, where the hand washing requirements, the social distancing, are things that their loved one who with the diagnosis may not understand, and may not, be willing to comply with. And I'm wondering what suggestions your team might be providing to these people.
Yeah, I mean, we have a special COVID part of our website now, which I hope people will look at. It's at UCSF. And, I think visual communication is really important. I think showing people by example, masks with hands, even people who don't understand language. Um, and I think organizing the environment in a way so that people are less likely to do things that they shouldn't. And I think this is very individualized. I think this is the sort of thing that you think about with AFTD and families. And I think I'll learn a lot today about what you're doing in this space.
I know you mentioned earlier that the challenges that our caregivers are facing who are still caring for their loved ones at home. We know that they're, for a lot of them, the professional and friends and family network of support and help that they've cobbled together, is obviously disintegrating to a great extent just because with the social distancing and with people facing their own challenges. But we're also hearing the challenges and the special pain of families who have a loved one in facilities, who can't go and see them. And again, the symptoms that these people may be experiencing puts them at special risk or really feeling anguish. And I'm wondering if you're hearing that as well. And again, if there's any advice that you can provide to those families.
Incredibly hard. And I think we all are experiencing this. My mother is 94 and she's in an assisted living facility. I think one of the things our family has done, we have set up a portal system that we can communicate with to my mom. My grandson Mason reads to her. He's 7, a half hour every day. And so I think we must be creative and think about ways that we can touch people as close to being there as we can. But there's no doubt our loved ones need our support now. And we as a family have doubled our efforts around my mom, who's a very special person. So I'd love to hear some stories about that as well today, how you are dealing with people who are at much higher risk of getting sick. There's no doubt about it. A lot of this COVID epidemic is happening in nursing facilities, jails, where people are crowded together. And I think we can help shape a new world in nursing facilities where there is more thought and caution around infections and things like that. So I hope we are changing the world as a group during COVID in a way that it will be better when this is over.
Yeah, I can tell you that we've already done some thinking about where we can turn our advocacy to this area. Facility care, was not top on our list. There are a lot of things that our community needs to be advocated for: more funding for research, coverage for insurance, better care. But specifically looking at facilities is definitely going much higher on our list based on what our people are experiencing right now. There's no question about that. I want to turn us maybe to research now for a little while. I hope people on this call know that your center has played a leading role in developing the All FTD Research Consortium. And I know you have some results from recent analysis of the first 5 years of those Artful and Lefty studies that have now been combined. So I'm going to invite you and me to turn off our webcams. Okay. And we will bring your slides up on the screen, and we will let you tell us a little bit about the research world right now.
Great. I might start by saying that AFTD has been incredibly helpful, extraordinarily helpful. critical for the research infrastructure that we have at the National Institutes of Health. And they helped put into legislation, if you can believe it. So this is mandated by our legislature that we have a major FTD program across the United States and Canada. And we now have $7.5 million a year focused on frontotemporal dementia, particularly the genetic forms, understanding how this disease progresses, and understanding, I think, soon how to treat it. So this has been a huge sharing with AFTD, the NIH, and scientists across the United States. So thank you, Susan, to your organization. So I'm going to talk about frontotemporal dementia. Next slide, please. And I'll take about 15 minutes to go through this. I was taught when I was growing up, and this is in the 1980s, don't pick Pick's disease. Was never diagnosed. People said, don't pick it because you can't diagnose it. They also said, don't pick it because it's too rare. And also they didn't think that neurologists or psychiatrists should be studying a disease where the main manifestation was behavioral. How wrong that dictum was. We now know that, and I think the fact that there's so many people listening today, we know this very well. This is a common illness. It's about as common as Alzheimer's disease in people between 45 and 64. Dave Knopman, looking at data in Minnesota, showed that it's the most common form of dementia in people under the age of 60. And people ask me, how common is FTD? And I always say, you know, whatever figures we have, they underestimate it, because people with ALS, we know 20,000 people afflicted by ALS in this country. I would say the majority of them either have frontotemporal dementia as well, or will soon be developing it. We have other disorders that sometimes begin with Parkinsonism, PSP, cortical basal degeneration, that are never counted in FTD figures. And also, I think we've learned from the NFL and McKee in particular at BU that head trauma can trigger a frontotemporal type dementia that is in football players called CTE. So Pick's disease, it's common. It also occurs after the age of 70. Susan and I came up with this figure of about 60,000 cases in the United States. Still an orphan disease, underreported, but I think there's one advantage to being an orphan disease. I think we can get the FDA to be more flexible about the clinical trials that we're about to embark upon. So I think a common disease that is being diagnosed more and more. Next slide, please. There are three main subtypes. There's a behavioral variant, and I bet many of you are on this webinar because of the behavioral variant. Unusual burden on caregivers. It begins as a psychiatric behavioral disorder. It affects the right side of the brain more than the left. We have two language variants, one semantic, one non-fluent, and they present initially with language disorders. I think we are much more likely to get the language variants diagnosed early, and the behavioral variant, because it presents as a behavioral disorder, which in our society isn't yet considered neurologic, is often diagnosed way too late and with catastrophic consequences for families. Financial ruin, people arrested, people alienated from family, when none of this had to happen if we were aware that this was a degenerative disease. Next slide, please. So I'm not going to talk about CTE. This is a disease that affects at least a significant minority of football players who play in the NFL. Affects some soccer players. It affects some wrestlers. It probably affects some war veterans coming back, but This is a slight variant of frontotemporal dementia where tau and often TDP43, the two big proteins of frontotemporal dementia, aggregate in the brain. This is Anne McKee's seminal paper about this. And what it's showing in brown here is areas that have been decimated by the tau protein that has been released by cells due to trauma and is progressively affecting the frontal and anterior temporal lobes. Next slide, please. So I think you know this. You could teach this seminar today from your own experiences, but I became interested in this very early and think about how we can use these early changes to diagnose this disease better. But what are they? They're selfishness. People who cared a lot about their family no longer do so. Passivity, we call this apathy once it becomes more severe. Addictive behaviors, alcohol, cigarettes, food. Sometimes multiple addictions happen in the early stages. Changes in self-identification, disinhibition, criminal behaviors, probably most important for the people listening today, loss of empathy for others. And these are often classified, seen first by people involved with psychiatric disorders. So I think we have to be really aware that these diseases begin psychiatrically, not with motor or even necessarily cognitive deficits. Next slide, please. So this is a slide that we did with our psychiatry department, Josh Woolley, and it points out that our patients are often, if they have BVFTD, misdiagnosed as having a primary psychiatric disorder. I think sometimes the medical system is particularly cruel to women, doesn't listen to women enough. And I think we notice that when a woman has behavioral variant frontotemporal dementia, about 70% of the time they are initially called psychiatric. In other words, the behaviors that they are exhibiting, identical to men, are much less likely to be recognized as a neurodegenerative disease. A big problem. Next slide. So I'm not going to talk a lot about anatomy, but I just want to make a point to all of you that the anatomy of this disease is driving what we see, what caregivers see in their own homes. And this is the bottom of the frontal lobe. It's called the orbital frontal cortex. It sits right against bone. It can be injured by trauma. In FTD, what we see is people are unable to regulate impulse control. They seek things and they don't inhibit themselves. They touch people inappropriately. They eat things that they shouldn't. They drink more than they should. And this is because these reward and punishment systems in our brain that tell us we should stop seeking that reward are not working. So I think the things that seem very psychological are really very anatomical. It's the anatomy of FTD that causes these impulse control disorders that are so hard for our caregivers. Next slide, please. This is an international study we did with Madeline Liljegren in Sweden, Elizabeth England, and we showed that almost 40% of our patients with BVFTD committed a crime. Some of them got arrested, some of them were protected by their families, but the punchline here is that the impulse control disorder, along with compulsions, sometimes to steal, to touch people who they shouldn't, lead these people to be arrested. And what a catastrophe it is when one of these people is in a jail. I did a special seminar with Melissa Fisher with lawyers across Oregon, and she told the tragic story of her father, who was arrested multiple times, never quite diagnosed as a degenerative disease. Memory disorders don't do this. So I think this is one of the unique problems that we all face. Next slide, please. Empathy. What aspect of FTD is the most troubling for people? I think it's empathy. I think loss of concern for children, loss of concern for you when you get ill, inability to perceive that there is sadness in the family. This is a huge aspect of frontotemporal dementia. And again, it's not an accident. It's not because the person you live with is cruel. It's because the part of the brain that is organized to feel and experience the sadness of others, the problems of others, the right anterior temporal lobe is degenerating. And this loss of empathy is directly related to this anatomy. I'll come back to how this loss of empathy affects caregivers. Next slide, please. Okay, and before I get into the research in terms of therapies, I just want to make one more comment, and that is, I've known this for years, but one of our visiting scholars, Akitoshi Takeda, studied our population and said marital dissolution infidelity significantly greater in BVFTD than any other neurodegenerative diseases. One of the major drivers of the infidelity and marital dissolution was loss of empathy. And finally, people who had marital dissolution or infidelity who had BVFTD had significantly lower empathy. So this is how anatomy can drive behavior that has a horrible effect on a family. Next slide. Okay. And this is to you, all of you here on this webinar. Bob Levinson and his group who study caregivers, Jennifer Merrilees, showed that the areas of the brain that are affected in a patient with a degenerative disease determine the neural correlates of caregiver health. So if you're a caregiver and your loved one has atrophy in these brain regions, you are more likely to develop a psychiatric problem or even a physical health problem. So I think this is an emergency when you think about this anatomy, caregivers, and then add COVID into the context of this. Okay, few words about where we're going in terms of treatments, because I know this is, next slide, very important for all of you. Yeah, okay. So one of the things that we have learned, this is Caitlin Casaletto's work, is that in these large cohorts that are being studied across the United States, Canada, and in Europe, we've learned that lifestyle, even if you have a gene that causes frontotemporal dementia, if you are cognitively active and physically active, you are slower to get the illness than if you are not active cognitively or physically. So this is one thing we know right away that caregivers can think about with their loved ones. And I think this is an important new finding that we will try to utilize as we think about better ways to treat people. And the other thing that we can do today, I think that is really important, next slide, is think about in our patients with language disorders that we now think that we have good treatments. Maya Henry at Texas, Mario Lugorno-Tempini, Marcel Meselam, Marie Grossman, all of these people have shown that if we retrain people who have the language variants of frontotemporal dementia, non-fluent or semantic, that we improve their language output. In this study, some people maintain gains for more than a year after treatment. So this can make a huge difference for people with the language variants. Okay, finally, a little bit about the biology of these diseases. Next slide, please. This is what all FTD is doing. It's taking large populations of people who carry genes that cause frontotemporal dementia, assesses their molecular status increasingly with tau PET, other imaging agents. We can study the molecules that are accumulating, think about the brain volume in people. We now have a biomarker neurofilament that seems to start to rise when the brain is beginning to degenerate. And then finally, the symptomatic person who is sick because of the gene. So this is the model we have. We think that the disease may go on for 15 to 20 years before someone actually begins to show elevations in neurofilament or drops in brain volume. But I think this is going to help us to think about when we should intervene. Next slide, please. So here's all FTD. I think it's just magnificent, this working between Foundation, AFTD, NIH investigators. This is led by Adam Boxer, Brad Beauvais at Mayo, Howie Rosen, and we have large populations of people with frontotemporal dementia, both genetic and sporadic, that are being studied longitudinally. Why do we think this is important? We think we are on the verge of having therapies for these populations. So understanding the natural history, how we can intervene and where we can intervene is really the effort of this massive group of really fine dementia centers. Next slide. We've also added to this something called REDLAT, which is a South American effort where we're looking at part of the world with 422 million people. We've learned that they have big families in Peru and Colombia and Brazil with genetic forms of the disease. We can start to think about the socioeconomic status of people in low education and low income parts of the world, to think about how this influences frontotemporal dementia. But this is going to add to our clinical trials efforts. So this is a very important project led by August and Abinez. Next slide. And this shows you places across South America that will be compared to all FTD. So we really now have an international effort. GenFi led in England, all FTD led in the United States and Canada, and now this REDLAT program across South America, now additionally with Alzheimer's Association funding, Tau Consortium funding, GBHI, we have added Chile and Mexico. So this is a massive effort, I hope you realize, to find a treatment for these degenerative diseases. Next slide. Okay, this is work from Susie Lee. I think she's shown that before someone actually gets sick, there is a pattern that we can see on the MRI in our progranulin carriers. This is probably the time when we want to intervene. So I think these large networks of people that we're following longitudinally, I think when someone reaches this hyperconnectivity stage, and we think it may be true of all the genetic forms of frontotemporal dementia, we may want to intervene before massive degeneration occurs. So biomarkers with imaging are very important for this effort. Next slide. We can detect atrophy in our patients very quickly once they're symptomatic. This is Sharon Shaw now at Stanford's work. And I think these biomarkers, it's an advantage compared to Alzheimer's disease because the illness goes quicker. We need fewer people in clinical trials if we have a treatment that's effective. Next slide, I'm going to say a little bit about one other biomarker, which is neurofilament. This is a filament that's released from neurons when they're dying. It starts to rise in the early symptomatic stage of frontotemporal dementia. And we think it's a really good marker for disease state, but also it will help us to decide whether a treatment was working. So imagine if we had a treatment that stopped the disease cold. Won't it be amazing to watch that neurofilament shown here in red to start to drop as the therapy begins to work? I'm not going to say much about the next slide, but it just emphasizes how important this is. So 2 slides, please. So I think we're at a very exciting time in frontotemporal dementia, and I promise you our investigators across the United States are going to continue, COVID or not. We are improving diagnosis of frontotemporal dementia. I think with caregivers in particular, often it's you who is the one who comes to the doctor with a diagnosis, not vice versa. I think we're finding new causal and risk genes, very important, because I think these genetic forms of frontotemporal dementias are going to be the ones that we can most effectively treat. We have the kind of funding now that we can really make a difference in getting large populations up who have potential treatments for them. And we have treatment trials already going on. Biogen is on the verge of FTD treatments. Elector is actively involved with treatments now for progranulin and C9 forms of frontotemporal dementia. So we are really tapping into the best basic scientists in the world. Inventor of CRISPR, Jennifer Doudna, is thinking about how best pharmaceutical companies in the world. And I think these trials are starting and will go on in this year. So be ready, be prepared. I think we have really exciting things coming. Thank you.
Bruce, thank you. That was, it's always exciting and hopeful to hear you talk about FTD and especially the advances that we're getting through research right now. We do have some people asking, we're aware that, of course, given the current sequestering situation, some trials have been put on pause. We know that, we've heard from our funded researchers that, of course, only absolutely necessary work is going on in the labs. Can you speak a little bit to the impact that you think this might have on research, or how and when the trials could get up and running fully again?
Yeah, so I think a couple points about the basic science. I think most universities, most basic science labs shut down, including ours, even though we have very low prevalence of COVID in San Francisco. We're gearing up to start again. I think labs are incredibly well prepared to deal with infection issues. They understand how not to contaminate samples, other people. So I think the basic science laboratories are about ready to open up. And I think that this basic science effort will continue in a very rapid and aggressive way. So I'm not so worried about that. Adam Boxer at our site has continued, I think, with clinical trials, people who have already been entered into clinical trials. So this is the only in-person patient assessments that we're doing at our center right now. But I think, again, we are starting to think about in a careful, slow way that will reassure that our patients and their loved ones are safe, that we will be opening up clinical trials. And, I think Elector has 2 trials going on. And I think as soon as the local sites can see new people, this effort will continue. So this, I think I am positive, optimistic, encouraging about. I think this is about ready to restart.
Oh, that's exciting to hear, because we know we had some real momentum coming into this year. To stay with COVID for just a couple questions, we are hearing that perhaps autopsies cannot be performed right now, especially with people who have been infected. And you and I both know that getting that final pathological diagnosis is such a sense of closure for our families. And I think this brings its own kind of heartbreak at the end of such a hard journey. Is there anything you can say about autopsies right now?
Yeah, I think some critical autopsies are continuing. The biggest problem with the autopsy happens before the autopsy starts, and that's in the morgue. And I think to obtain the brain requires a process that is likely to release virus. So I think where this is done, there have to be really careful safety measures taken. It's happening, and I think, but that's the rate limiting step. I think once these brains come to our research centers, the risk is incredibly low for people. So the other thing I'd say is we are continuing autopsies in people who have not died from COVID, which is the vast majority of people with FTD. So I think our research into the autopsy components of FTD has continued. And I think that's true across the country.
Great, great. Another COVID question, have there been any studies that show what neurological implications, if there are neurological implications of a COVID-19 infection, and is there a relationship between the cytokine storms and any neurological issues?
Yeah, great question. So I worry about the 1918 Spanish flu epidemic. When I was a fellow, Jeff Cummings showed me people who had recovered from that infection, the influenza of 1918, who developed Parkinson's disease. So I think this is something that we're going to keep an eye on. For the most part, studies here and elsewhere, Michael Wilson suggests that for the most part, the COVID virus does not get into the brain. For the most part, we see very little meningitis, encephalitis, and that was much more common in 1918. So I think it's possible that we will see neurologic problems in the long run, 10, 15, 20 years later. Certainly people are developing psychiatric symptoms with COVID. And I think we know that the cytokines that are released, even with the flu, even with the common flu, can make people feel bad, tired, sad, sometimes really depressed. And so I think this is something that when you get a really bad flu is really common. And we're seeing plenty of this with COVID. So caregivers who are unbelievably depressed when they get sick with this flu should realize that this will pass.
Great. A more general FTD question. Somebody's asking if it's possible for an FTD patient to have more than one type of dementia. So for instance, Alzheimer's and FTD at the same time.
Great question. And I think I think early age of onset tends to usually be one pathology. So I think if you're under the age of 70, the likelihood that you have Alzheimer's disease or Lewy body contributing to the syndrome, it's not impossible, it happens, but it's low. If you're 80 and you have frontotemporal dementia, just like if you're 80 and you have Alzheimer's disease, you are likely to have other pathologies that begin to emerge, vascular, Lewy body, Alzheimer's. So I think the older our frontotemporal dementia population gets, the more likely they have dual pathology or three pathologies. We do clinical pathologic events at UCSF where we think about the clinical story in group and then the brain changes. And I think we're learning that more and more, the older someone is, the more likely that there are to have multiple pathologies. But I think most of you, the people on the phone here today, have people who are in the younger ages and probably have only FTD as the pathology causing the degeneration.
Next, we have a question from a woman whose husband just died of FTD who had a MAPT mutation in the tau gene. She's asking how likely gene editing might be as a cure for FTD genes like MAPT or the C9 gene.
Long-term, incredibly hopeful. So I think CRISPR invented here in San Francisco, Berkeley area, in the Doudna lab and also at Harvard, other lab. These are labs that are beginning to think about how we could edit out bad forms of tau. I think in the long run, this would be a cure. It would protect even gene carriers from ever getting the disease. And I think might really help people who are sick with diseases related to tau. And that includes Alzheimer's disease. What I would say to this brave woman is that it's really important for science to get as many people who are at risk for developing frontotemporal dementia from the tau gene to participate in these trials. Adam Boxer told me just yesterday that there are several pharmaceutical companies ready to go with really advanced forms of biological manipulation of these genes and are ready to go in a tau study at the end of the year. So I think the rate limiting step here is number of people who are sick or at risk. We need more and more of these people in studies. So I think this is something, what I'm seeing with COVID is unbelievable altruism. And I think what I see in this FTD community is altruism as well. But I think you can really change the world for the future if you are participating in these trials.
Great. And there's a related question here, so I'll give you time to give a plug here. Somebody's asking how they sign up for any of these FTD research programs.
Yeah, I think I would be glad to answer any questions. I think there are local considerations for many of you. I think you have loyalty to your own cities. In Philadelphia, at Penn, there's wonderful work. New York, Columbia in particular, doing wonderful work. Harvard. So, but I would be glad, and I think with Susan, we'd be glad to talk with you about this. I think we'd be at UCSF delighted to see anyone via telemedicine if you think it would be helpful, and make that the first step toward getting you into the right research.
Yeah, I would add that everybody on the call, I encourage you to look into the FTD Disorders Registry. I believe it's ftddisordersregistry.org. This is a nonprofit that's been founded by a number of nonprofit organizations, and the idea of the registry is everybody in the community can register to contribute to research. And if you're there, you will get notification as different trials and different research studies go online. So that's maybe one good central place to make sure you know what's happening at all of these centers. Turning to more of the care side for a couple questions. Do you suggest palliative care at diagnosis for family support?
Yeah, we when we see somebody, and this is work led by Kate Poseen at our site, we go through advanced directives immediately. So I think the worst thing that can happen, I think, to a family is a family who do not want heroics to happen when somebody with FTD is in the end stages of disease, to have them intubated, driven to hospital via ambulance. And so I think the first thing is setting, your priorities in place, having advanced directives so that the loved one and you make sure that the last stages of this disease are handled properly. The other aspect of this is I think palliative care can be, and hospice and the last stages can be incredibly helpful to people. And I think talking with a palliative care team early on, I think would be a good thing. And I think we have extensive efforts at just about every major medical center around this palliative care. It's something new. It's the last 5 to 10 years it's occurred, but I think it's helping loved ones cope with the last stages of the illness.
Mm-hmm. Another person is asking if there's any training in the mental health community about FTD, especially the behavioral variant.
Yeah, great question. And I think AFTD does some. I think we do a little bit, not nearly enough. I would say I think all of us, everyone on the phone is an educator around frontotemporal dementia. I can't tell you how many of my patients come to me because the family first realized that this was frontotemporal dementia. I think the sort of events that AFTD is doing, Melissa Fisher's effort with lawyers, I think very important, because sometimes the legal system is the first one to see these people, and I think important they get the right diagnosis. I think emergency rooms have to be aware of this. You name it. I can't think of an area where we need to do more education. And Susan might say a word about her perspective about how we can do more in this space.
Well, as you say, Bruce, it's a major goal here at AFTD. It's a challenge when it's such a rare condition. And as you covered earlier, the confusion in diagnoses is so dramatic. You know, you and I both know that a family dealing with behavioral variant FTD, it's on average almost 4 years before they get that accurate diagnosis. And most of them have gone through a number of misdiagnoses, many of them in that psychiatric bucket that you mentioned earlier. I will tell you that one thing that excites me is the number of people in our community who are raising their hands to help, to volunteer, to help educate people in the community. As you say, a lot of times they find the diagnosis first. And we're finding that when we create education materials of any sort, it is our family members who are really on the front lines delivering them to providers everywhere. So as with everything else with this disease, it takes a village, and we're all on the team. And I think that's the way we'll get the job done.
Susan, I might mention something I don't even think you and I have talked about, but the International FTD Society's meeting is in October is unable to be held, but I think our society has made a decision, and we'll work with AFTD around this, that we are going to have some sort of a major conference for families and for loved ones. And we'll do this with AFTD by webinars like this, by Zoom meeting, but we're just in the realization how important this educational event is going to be. And you'll hear a lot more about this in the coming month.
Yeah, we look forward to partnering with you all on that as well. We're getting a few more questions about, one here is about the value of knowing a family's genetic status. We know that this is a difficult decision for lots of individuals in our community, and I wonder if you would speak to both the value of them knowing their own status, and I know people can participate in the familial studies without knowing their personal status, which is a wonderful thing.
Yeah, I think this is a very individual decision. And I think if you have a family with a genetic form of FTD, I think for each and every one of you, you're going to want to make a decision about whether you want to know, whether your loved one wants to know. I think, as Susan says, even if you don't want to know, I think you can participate in these longitudinal studies by giving blood, by getting MRI scans, but the team agrees not to disclose to you or anyone else for that matter, whether you are gene positive or gene negative. I think for some people, it's very important to know, and they think it can help them with advanced planning, with financial issues, give them a sense of security either way, whether they know or not. And so I think this is why genetic counselors, and we have some great ones nationally, talking with the family can help you decide what the personal right answer is for you and your loved ones. I think the advantage of knowing is, of course, the opportunities to participate in research in particular, and to participate in disease-modifying therapy approaches. So I think as we get better and better at treating this, I think more and more people will want to know.
Yeah, I agree with you. And we have, I guess I'll say one final question because I see we're getting close to our hour. But there's a question about how people with sporadic disease will benefit from those familial studies.
Oh, I'm pretty sure that the molecular approaches to the familial forms of FTD will immediately apply to sporadic. So I think if we have a good treatment for the MAPT mutations of frontotemporal dementia, we will be able to effectively treat the non-fluent progressive aphasias, 85% of whom have the tau molecule. So I think this is a two-step process. Prove that we can treat a specific molecular form of frontotemporal dementia, then apply it in a precision medicine smart way to larger populations of people with sporadic FTD. It's the molecule that is important, not so much that it's genetic.
Right. And I might, you've teed up a nice plug that I like to make here, which is the importance of biomarker research, which of course is, we need so many people to participate in, but until we have that biomarker data, we don't know necessarily what molecule a sporadic patient, what's causing their disease, isn't that right?
And I think Susan and AFTD has a magnificent program. I'm not, are we allowed to say the person who funded it? Maybe not, but anyways, it's a magnificent person who funded this.
We'll skip that, yeah.
Yes.
There are many magnificent people in our community. Yeah.
Oh, absolutely. Yeah.
That's great. We do have a number of additional questions that we're not going to have time to get to. I would invite everybody to submit them to AFTD's helpline. You can email info@theaftd.org. We can answer these questions. We can pass some of them along to Dr. Miller. And I thank everyone. I'm sorry we don't have enough time to get to all of the excellent questions. But we are nearly the end of our time. I want to thank you again, Bruce, for all your time and for your thoughtful leadership in this field. It's so important to all of us. We hope you all found this presentation to be informative and leave with new tools and perspectives you can use during these challenging times. We will post the recorded webinar on AFTD's website under News and Events and send out the link as soon as it's available. We are compiling new resources on an ongoing basis on the COVID-19 and FTD section of our website. You can access this under the Find Help menu on our homepage. Our helpline and Facebook groups offer individual information and support. And we're working with AFTD support group volunteers who want to offer virtual meetings for their existing support groups, which of course can't be meeting face-to-face right now. Please let us know if you have any comments or questions after today's presentation or about other ways AFTD can assist you in moving forward. Thank you again to our webinar sponsors. And finally, please note that our webinar series will run through the first week of May. We hope you'll join us for the fourth installment, which is next Thursday, April 30th at 4 p.m. Eastern, when the Very Reverend Tracy Lind, who is Dean of Trinity Episcopal Church in Cleveland until her diagnosis in 2016, will present The Playlist of My Life, Building a Toolbox for FTD. So until next time, thank you for spending this time with us, and thank you so much again, Bruce.
Thank you, Susan.